So we start with our first panel discussion, which is on practicing community inclusion at grassroots communities. And I would request the panelists to take the floor. I would request Ms. Alicia Carroll from CBM Australia. Already there? Okay. We have Ms. Chinta Munasinghe from NCS CAF, Sri Lanka, who is working with us as a research consultant and also a member of TCI in Sri Lanka. We would request Richa Sharma from the Secretariat, Kavita Nair from Bapu Trust, and Samuel Macharia from CIC Kenya.
Good morning, everyone. My name is Alicia Carroll and I'm from CBM Australia. And welcome to our panel discussion on practicing community inclusion at the grassroots level. I'm honoured to be the chair of today's panel, and I'm excited to delve into this really critical topic with our esteemed panellists. We recognise that in achieving Article 19, there must be realisation of a range of related rights, and ultimately, transformation at the grassroots level. Transformative practice means actively enabling redistribution and sharing of power and control over decision-making, resources and benefits. TCI has not only played a critical role in shaping the discourse and pedagogy around inclusion, but they've also nurtured a community of practice around transformation through supporting implementation of CRPD-compliant community inclusion models with their members, as well as cultivating partnerships with many organisations such as those of you here today. In this panel discussion, we will learn about work TCI has been doing in developing tools and resources to support its members and others in community inclusion. We'll learn from their research they've been undertaking over the last 2 years on community inclusion models. And we'll also discuss one of the longest standing programs demonstrating non-coercive support for people with psychosocial disabilities, founded by Bagavi. And finally, we'll hear about how TCI has supported members in Kenya to frame community inclusion for people with psychosocial disabilities and the outcome of TCI's Catalyst grants. Now, we won't have time for Q&A, unfortunately, at this point, but we will at the end of the day. So please do hold on to those questions. And so without further ado, I would like to invite our first speaker, Chinta Munasinghe from NCS and the Community Action Forum in Sri Lanka. And she's also the TCI research consultant. So let's give her a warm welcome.
Hello, hi, good morning, and Ayubowan, that is long life. Yes, I think I was given 3 questions in my presentation. One is how to measure impact of inclusion, what is community inclusion indicators, how can we implement HR-based community mental health programs using this tool. And to start with, measuring impact and also synthesizing information is not a new thing to our communities. But the wording terms are different. If I say that every day, every minute, every occasion, there's always information generated, it is assessed, and then it is synthesized and shared. How? And we call it gossip. We call those people Reuters, the monitors, right? They are available in our communities everywhere, even here. So it's not a big thing. But when it comes to development projects or whatever projects, people like to do work, but they don't want to document, they don't want to really generate information. It's like, you know, It's very difficult thing. Oh my God, now the donor wants this, I have to collect everything and then we have to return it. Numbers, statistics, data, qualitative information, what nonsense, right? So when it comes to inclusion, how can you really measure inclusion? It's just a value, right? Because anyway people are included. Now these days, because it's a keyword, every project, every person thinks that I include people. There's no exclusion. But basically, is that true? When it comes to persons with psychosocial disability, we feel a lot of times that we are excluded. But then our service providers and authorities think that we are included. Right? So this is the issue. So we thought at TCI, how can we really measure it? At least document it, where we have been included, right? So this was started like whether it is possible, can you really measure the impact? So all those questions came into our mind. And then all over the members of the TCI-Global got together and developed, the first initiative was, we just put some indicators. First we do some domains. Okay, let's decide which way, what are the areas. So we developed 9 domains, right? So these are the domains together we developed. First one is actions on inclusion, awareness meetings in the community. How to do awareness. Inclusive, second one is inclusive community support systems and networks. Third one is access to mainstream services. Fourth is access to healthcare support. Fifth, creating an enabling legal environment. Sixth is facilitation of financial inclusion. Seventh is preparation for leaving the institutions. And the eighth, working with persons with disability. And the ninth is actions to support during crisis situations. So these are the 9 domains that we thought we should concentrate on. Then what happened? Then we developed indicators. Interestingly, some indicators are not indicators, but actions, right? Then only I got involved, and the first job TCI gave me was that, okay, you develop something, a tool. So it was like so many information in that workbook, and I'm supposed to do a tool. That was a big challenge for me. But of course, like having 33 years working with donor-related projects in Sri Lanka and also Africa, the other problem was I was not a simple kind of tool maker. So I'm a very comprehensive data, because I have been working in the small enterprise sector. So you always have like cost per client, return on investment. Those are the kind of indicators I was thinking. Then I found that it is not really user-friendly, because in our things, we should not ended up having another mental health condition by filling my tool. So I have to make it simple. That's another challenge. So somehow we managed to do it, and we call it Community Inclusion Indicator Tool. It is, what we developed was based on, we selected certain indicators from under each domain and try to make it a, something like, we never thought about it's a monitoring, but I put even numbers, because I thought that this tool should be useful to any member who may have donor-related projects that they have to do reporting. So how can they use this tool? So that is also we kept in mind. But it is more like a action-related tool. So the purpose was capture the range of microactions implemented to enable community inclusion, utilize it as a CRPD compliant compass to assess and align inclusion actions with the CRPD, document best practices, and use as a monitoring tool. So the first thing we did, we somehow managed to make a kind of a tool, and we basically piloted in 4 countries. That is Sri Lanka, Thailand, Uganda, and Kenya. So when we were doing it, actually there are different levels of stakeholders, like it was like management teams were involved, field officers, field staff involved, as well as in Sri Lanka it is mainly volunteers and real community people were involved. Because we wanted to see that how effective this tool, how they will be captured, whether it is, understandable by each level of the people who will be involved. So around these 9 domains, then we developed the tool. So, and we found that, I will show you just a sample, but these were the features we found it. It's not we, actually the who were doing the piloting were saying, these were what they said. It is kind of an adaptable design to suit their kind of work. And then it is a user-friendly tool, and it enhances documentation and the information synthesis to suit different audiences and purposes. It can be useful. Then it is a simple tabular format design in Microsoft Word. So that is quite, many of us are using it. Excel sometimes, I get headache when you are using. So we have to think all of these. Then supported with descriptions of contents in the footnotes, if anybody is confused. So it is available in e-versions or a hard copy. So you can have both ways. Then it includes glossary with the definitions and descriptions. So basically it records quantitative and qualitative data, but it's a very simple tool. And FISA, I hope you can put just to get a glimpse the tool. The first one is actually the domain. Like one is actions on inclusion awareness in the community. Then there are 3 indicators, like types of meetings held to expand direct outreach to diverse community members, stakeholders. Then indicator 1.2 is types of materials used, and indicator 1.3 is number of sensitization meetings held with community groups on inclusion topics. So there's a table then to record. Can you go up, Lisa? Yeah, the table. So under the type of community meetings, you can put whatever actions you have done, like it may be awareness programs, community consultations, little small groups meetings, whatever. And then there is what kind of awareness materials you used, you can record it there. It can be posters, it can be even a drama or whatever. And then number of meetings. So that also we divided. There may be topics or themes you will be doing. So if it is on inclusion, then how many you can put it. If it is on psychosocial support, then you can put accordingly. Then the number of participants. Basically we put it like male, female, non-binary. But if you want to expand it, like, some people may want to have even diversity of disabilities, psychosocial disability or persons with physical disability, like that you can expand it according to your requirement. And then the codes from the participants. Like when you have awareness, usually at the end of the day you get the feedback. So then there will be nice quotes coming from the community, so you can record it. In my case, like in our organization, always have process documentation. So we will record those things very well, and then we put into this. So you can use it in your narrative report. So down is the footnotes. Under each column, what you can enter, there are with some examples. So that is very simple tool. So like that, under each indicator, we have developed this kind of table. So this is what I said. You can have like, according to your things, like different ways. Some want to have so descriptive, like, each and very minute details. If you have it, you add it and enter. So that's the tool. I think my time is on, and that is what I want to say. So it's not a new thing. Monitoring, it's not a new thing. We'll have tool, very, very indigenous tool. So this is just kind of documenting, which is what we don't want to do. Thank you very much. Yeah, there's also in your, we have got some gift, like a bag, and inside that there's a flyer about this tool. Thank you.
Thank you, Chinta. Clearly there's been a lot of thought and effort gone into conceptualizing what community inclusion is as a construct, and then how do we actually measure that. And developing a tool that's practical for OPDs and other organisations to use is no small challenge. And many of us may not be good at telling the story of the work that we're doing at the community level, so having tools to help guide us in both the process and also the outcome is so critically important to understanding and learning about transformation at the community level. So thank you so much. We look forward to looking more at the tool. I'd like to go now to Risha. I know TCI has been undertaking a project over the last 2 years and providing a roadmap on its work with member OPDs. I wondered if you could tell us a little bit about the findings from the research that's been happening and what your learnings from the field visits have highlighted for you. Thanks.
Thank you, Alicia. Good morning, everyone. It is an absolute honor to share with you today the journey that TCI undertook in the last 2 years through this project on community inclusion. From January to May this year, we visited 4 member countries, like Chinta said, Sri Lanka, Thailand, Kenya, and Uganda, where we met our members and leaders. We visited their communities, we visited their organizations, heard their stories, learned from their experiences, and witnessed the practice of community inclusion at the grassroots. In addition to being a research project, these visits were opportunities to listen, to observe, and to truly understand what community inclusion means and looks like as a viable practice. We conducted, just to give you an idea, that we conducted focus group discussions with community members, and we conducted in-depth interviews with organizational staff, with key leaders in the organization, and some participants of the programs of the OPDs. And for this particular intervention, I would focus on 2 aspects. That one, we identified some key principles that define community inclusion models. And then we also looked at dilemmas that OPDs face while putting these principles into practice. So for key principles, the first one that came out very strongly was that community inclusion models should have an outcome of inclusion, and that of restoring dignity, autonomy, and independence in the lives of persons with psychosocial disabilities. They should not be merely focusing on recovery or symptom reduction. Along with that, when we are working with persons with psychosocial disabilities, there are some non-negotiable principles that we must always abide by. For example, ensuring that identity and intersectionality are respected, ensuring that lived experiences of the persons, of the individuals, are valued, ensuring their rights to make their own decisions with needed supports are upheld, to name a few. Community inclusion, on the whole, is possible when we foster collaborations and partnerships with a wide variety of stakeholders. And in addition, there was also a principle that we should be focusing, our community inclusion models should be focusing on promoting community ownership and local solutioning, where people come together to support each other and address needs of its people. This also feeds into strengthening capacity of community support systems, which includes informal networks and people in our circle of care, such as our families, friends, neighbors, and peers. Talking about peers, peer support came out as a particularly powerful form of support, not just as therapy, not just as a service, but as spaces to build a sense of solidarity and to restore hope and build confidence of persons with psychosocial disabilities. We've been hearing about enabling access to support services and mainstream services wherever available, and this also came out as a critical principle to ensure independent living in the community. While working with persons who have been deinstitutionalized, it's not only about preparing individuals to return to life in the community, but also about transforming the communities themselves for true inclusion to happen. It is pertinent to respect and work with persons' cultural ways of well-being and healing, which work as informal systems of support and offer more than just therapeutic value, because they foster a sense of community, a sense of comfort and trust by drawing on shared cultural understanding. Sometimes they are beyond our comprehension, but going back to the previous principles, we respect the choices made by persons with psychosocial disabilities and meet them where they are and respect their ideas and ways of just being. In addition, actions to enable legal and financial inclusion must remain central, and advocating with stakeholders for rights, dismantling discriminatory systems and policies, and creating pathways for independent living are non-negotiable. This was just a snapshot of some of the key principles that we found out while we were doing these field visits. But with these models also come dilemmas, especially questions around CRPD compliance that must be confronted as OPDs, as inclusion practitioners, and as advocates. It is important to reflect, introspect, and monitor our own actions as OPDs to understand whether OPDs are being fully CRPD compliant and what dilemmas do they face while practicing community inclusion in real life. For instance, when working with persons with psychosocial disabilities, are we truly respecting their choices? Or are we unintentionally imposing what we think is best for them just because we are in OPD? For example, there is a community awareness meeting happening in the community. The person does not want to or wish to attend it at that point in time. Do we respect that decision, or do we work with their family to persuade them to attend the meeting then and there? So like before, as I mentioned, are we meeting them where they are on their journey, or are we in some way controlling the narrative? Another dilemma is how we approach awareness activities. A lot of our OPDs, we focus on awareness raising and sensitization within communities. But as you all know, that awareness activities in the mental health realm focus on providing information about availability of medications, where the services are located, where the treatment centers are. So we as OPDs, we have to ensure that are these being covered in OPDs programs, or are we creating awareness around the CRPD, about human rights of persons with psychosocial disabilities, about the right to make decisions, about providing support when it is needed, as per the will and preferences, to name a few. Communities often see persons with psychosocial disabilities through the lens of extremes. So someone experiencing severe distress, shouting, being angry, being violent, that's how communities refer to persons with psychosocial disabilities. But there's a spectrum of distress and disability, and everyone, not just persons with psychosocial disabilities, are located somewhere on this spectrum. So as OPDs, we should be cautious about what we are portraying to the community through our awareness activities. Are we feeding into those stereotypes by only talking about high support needs or extreme distress phases? Or are we talking about the spectrum, and trying to locate the person on that very spectrum itself? Then there is the question of the stories we share and tell. As I said before, that peer support is a very powerful tool for persons with psychosocial disabilities, and we often look at each other as role models, and that's great, and that's how we get our strength. But we often came across this dilemma of should we always be highlighting only success stories of our recovery, of returning to life as it was before distress, or should we also share stories of survival, of healing, of simply moving forward in ways that are meaningful to the person? And finally, one of the most painful dilemmas, the persistence reliance on institutions and institutional care. Friends, family members, and community groups often feel they have no choice but to leave persons with psychosocial disabilities at hospitals, care homes, and institutions. And why? The most common reason they said was because they don't know how to support them during the high high support need phase. And they also feel that we would be safer there, and persons with psychosocial disability will get the required care. This highlights a gap, not just in services, but also in understanding, in alternative support models within community, in availability of support services, in building capacity of supporting persons with psychosocial disability, and overall in CRPD compliance. So just ending, just tying up these observations and these thoughts, I wanted to also, I wanted to pose this question of where do we go from here? And I will just highlight 2 key points in that regard. First, we must hold ourselves accountable. And we've heard in the last 2 days from our member from Taiwan that accountability is a value that needs to be upheld by the OPDs themselves. CRPD being our compass, we must constantly reflect on our actions and ask ourselves if we are truly being CRPD compliant. Are we empowering individuals, or are we inadvertently reinforcing dependency or control? Second, and the last one, we must put in ongoing efforts to bridge the gap between principles and reality. Inclusion cannot be achieved in isolation or just in theory or just through words. It happens in the very chaotic, real communities with their layers of complexities and contradictions. We as OPDs must be constantly listening to persons with psychosocial disabilities, also listening to the communities, and tweak, twist, and adapt our ways of implementing CI models while upholding the CRPD. And I would end here and also would warmly thank the 4 organizations that hosted us in their communities and generously opened their doors to us for sharing these learnings with all of you here. Thank you.
Thank you so much, Risha. Risha is the Advocacy and Research Officer at TCI-Global and obviously has hugely rich information from that research process, and those findings help give us guideposts for how we are developing CRPD compliance. And I think you summed it up yourself in terms of, we as a community of practice, we can help keep ourselves accountable. We know that it's easy to make mistakes, and so providing a safe space for us to do that and to consistently reflect and improve on our own practice to ensure that alignment. I'm going to jump now to Kavita. So Kavita Nair, many of you will know, is the board member of Bapu Trust for Research on Mind and Discourse. The founder of this vision of inclusion and leading to formation of TCI through the leadership of Dr. Bagavi Dava. Kavita, you're going to tell us a little bit about the very long-standing program and many 25 years, I think, of experience doing community support systems and services on the ground in Pune. And we'd love to hear about how you're developing resources out of that for others to be guided in this process. Like less than 10 minutes? Sorry.
All right. Thank you so much, Alicia, and again, a very warm morning to all of you. So to give you a little bit of context, the Bapu Trust for Research on Mind and Discourse is located in Pune, and we have a direct service implementation program. It's called the Seher Community Mental Health and Inclusion Program. Seher works in low-income communities of Pune city. So Seher was founded in 1999. We started as an advocacy and research organization, and one of the questions that challenged us at that time was, we were strong advocates and we had a lot of research to back our advocacy, especially about rights violations of persons with psychosocial disabilities. But we would be questioned about, okay, so what are the alternatives? If you're saying that this should not be done, can you tell us what should be done? And we had no answers to that. So that led to the birth of the Seher implementation program in low-income communities. So then we started the Seher program in 2004, and we covered about 30 low-income communities in Pune city from 2004 to date. At that time, we started as a clinical model. I will come to that shortly, what it means and what it meant, and how we transitioned from a clinical model to a social model, and eventually to a model which is an inclusion model in doing community mental health work. Right now, the work in Seher is not only going on in Pune, that is one city in Maharashtra, the state of India, but it is also being scaled to 2 other states of India, which is Madhya Pradesh and Chhattisgarh. As of today, Seher has got model field programs across 89 sites in the country, which includes low-income urban communities, villages, low-income semi-urban communities, rural communities, communities in conflict regions, and indigenous communities. So when we started the program, Seher, in 2004, this is what our program looked like. We had a top-heavy pyramid, which means that we had a lot of experts in our team. The approach was individual, so we were concerned with recovery of the person, treatment of the person, ensuring that the person gets better and feels better when they come into our program. We offered clinical services, so we had a psychologist, and we used to refer people to a psychiatrist from the public hospitals. The services were formal in nature. So it had the psychologists would do talk therapies, use different kinds of therapies, REBT, CBT in working with the persons that they met through Seher. And at most, a referral would be made to the psychiatrist, which of course meant that, which was about treatment of the person. So when we were doing this, most of the people did not turn up for our services, and they did not find it to be very useful. So they used to challenge us, and they used to ask us, especially the women. I think I always quote her in all my presentations, where she told us that, so this woman was being beaten up by her husband, and she was a woman from a low-income community where we were working, and she said, okay, I will come every week, I will attend the counseling sessions, I will even go to the psychiatrist and I will take medicines because you say that I am depressed. But will my husband stop beating me? Will there be food to eat in my house? Will my children go to school? And we had no answers to offer her. We had nothing to support her in the Seher program at that time. So this is just one of the challenges that we faced, and mental health was not a priority for people. Talking was not a priority for people, and the very restricted way of looking at the individual did not get us anywhere. So we used to look at, so we had a typical mental health response. Somebody comes to us and we are looking at alleviation of symptoms, we are looking at a recovery-based model. So we would have, when we screen people and we identify their needs, our identification would be depression, anxiety, schizophrenia, psychosis. That is how we started our journey. That model failed. And today I can say thankfully so. Yeah, okay. So then we always have an overlay of research with all the programs that we do in the Bapu Trust. So we started looking at where we were going wrong. Why is it that we were not able to address the challenges faced by low-income communities? So we decided to flip our program. So the flip meant that we needed to invert the pyramid. From a top-heavy, expert-heavy model, we needed to move into a grassroots, a community-led heavy model. We needed to have a community approach. From recovery, we needed to move to support. And we needed to ensure that not only the formal services, but we also have a wide range of informal and non-formal services as well as systems as a part of the intervention program. We definitely needed to respond to the social needs of people, and we needed to make way for CRPD. So the flip happened in, I think, 2007. So 2004, Seher, medical model. 2007, Seher, social model. So we started looking at a different kind of response in people, psychosocial response. So initially it was mental health response, now we move on to psychosocial response. So we started looking at where is the experience of distress coming from, what are the stressors in the person's social environment, what can be done to mitigate the stressors. So we were looking at, so initially we were looking at anxiety. We started looking at loss of job, violence, breaking relationships, caring for somebody who's sick in the family, and so violence at home, and so on and so forth. As we were doing this, again, our studies indicated that people were coming into our system, many people were benefiting, many people were recovering. Most people were feeling included, but there were people who were not feeling included. So we did another study which was about understanding what is recovery and what is inclusion. Are they the same or are they different? And if they are different, how are they different? So we discovered in our programs that recovery in fact is remedial in nature. It is therapeutic. It responds to identified mental health needs of a person. It does not always lead to inclusion. A person may feel better in terms of their psychosocial difficulties, but this does not mean that when you feel better, you're able to participate or to make choices, you're able to have control, you're able to have agency, you're able to make decisions and implement those decisions. So a person may recover, but the impact on community systems and structures may not happen at all, because you're still only working with the person and you're not working actively with communities around the person. So then this posed another question for us. Okay, what do we do now? We have moved from a mental health model to a psychosocial model. What more can we do? So around 2009, and this was also the time when Bhargavi was very intensely involved with the CRPD, she took very, very radical steps. She closed down the Bapu Trust, and she said that we are not working in the communities until and unless we are very, very sure about facilitating outcomes of inclusion in all our programs. So then we transitioned, I would say. It was not only a flip, but it was a complete transition from being a mental health organization to an organization that works in psychosocial disability, where we went beyond just health and care and experts. We reframed our understanding. We moved to a grassroots model of working. We have a wide and diverse array of non-formal and informal networks and services. We ensure community-based doorstep reach, and we do heavy partnerships because everybody has something to contribute within an inclusion model. So there is role for multiple stakeholders in the community. There is in your packs that TCI has given, there is a photo story document which has a lot of co-design charts of the Bapu Trust, the Seher program. So we have a psychosocial needs spectrum. We have a circle of care. We have what we call as 8-point recovery framework. So I will invite all of you to look at that. We will not have the time to go through all of it. But coming to some of the difficulties we faced at that time, I think we have been here in Bangkok for the last 2 days, and we have heard from our peers that inclusion, I think in spirit, everybody wants to do that. We all understand inclusion, but how do we practice it? Deinstitutionalization, I think nobody would say that, yes, institutions are good. I mean, we are all saying that we don't want institutions. But how do we ensure somebody from an institution is able to come outside and stay outside? How do we ensure that people who are outside do not go back into institutions? Should everything be done by persons with lived experiences or persons who identify as persons with psychosocial disabilities? Is there role for others? What roles are they and how far can they come? What do you mean by community support services and community support systems? These are all concepts which we have been hearing for a long time now. And what we have done in collaboration with TCI is we have broken down those concepts into practices, into actions that can be directly applied in field programs. And along with TCI and a lot of other member organizations from the TCI network, we are coming out with a community resource booklet. The resource booklet is organized into 8 chapters. So it starts from concepts, and then there is the middle section speaks about the transitioning the concepts into practices. And the last section is entirely about practices. So to give you an example, for somebody in crisis, we would understand crisis as, we still do, in fact, that's what I have seen in the last 2 days. Crisis is associated with increase in symptoms, relapse, somebody not taking medications. But I think another way to reframe that is we understand crisis as that moment when you face a person with a psychosocial disability would face highest restriction in participation. So the concept is highest restriction in participation. What does that mean in practice? It means that the person is not allowed to step out. It means that the person is not allowed to reach out to others. It means there is no supported decision making, but there is a lot of substituted decision making. It means the person does not have access to the things that they would want at that point of time. It also means that crisis it's not lifelong, it doesn't continue. Crisis comes and crisis goes. And there are things which can be done differently at different points of time in this spectrum. So we will not have the time to look at all the chapters or even any of the chapters, but happy to talk to any one of you, anyone who is interested to know more about the booklet. We are hoping by next year we would have this booklet come out, and it will help to translate a lot of concepts into actual practice in communities. Thank you.
Thank you, Kavita. Thank you so much for so humbly sharing your journey. It's not an easy one, and the realization that the real growth and outcomes come from not reducing a person to their symptoms and a label, but really understanding an individual within their own homes, communities, lives, in their context, and tapping into those community support systems that can be tapped into for people with psychosocial disabilities and offer such a sustainable way to strengthen communities and help them become more resilient. I know that you have so many practical examples of how you have provided support to individuals and communities, and so I really encourage all of you here to take the opportunity to speak to Kavita, because they've really done that deep thinking about the dilemmas and the opportunities. So thank you so much, Kavita. Okay, so we're going to move to our last speaker now, Samuel Makaria from CIC Kenya, organisation representing people with psychosocial disabilities. And I wondered if you could tell us a little bit about how TCI has contributed to reframing of the momentum in Kenya and more broadly in Africa for community inclusion of people with psychosocial disabilities.
Thank you very much, Elisha, for this particular moment. And what I'm going to present is just, the content is included in what my previous speakers, Chinta, Richa, and Kavita have presented. Championing for Inclusive Communities in Kenya was actually formed in Bangkok in the year 2022, April, during the COVID-19 emergence. And the movement in Kenya had already been threatened by the slowing down of the donor community, as well as change of priorities into COVID-19 response. And in the meeting, I was with my colleague Elizabeth Obati, and Bagavi shared a clear vision on TCI for the community inclusion based on Article 19 of the CRPD. So it was during my fellowship program by TCI-Global, and we were lucky to have Championing for Inclusive Communities registered within a period of 6 months in Kenya by the National NGO Coordination Board. And for our first meeting, which was held in Nairobi, and the sub-region meeting, which was held in Addis Ababa, late in July, a lot of issues came up, and I have to really thank Dr. Samuel Kabwe, who is in this meeting, just seated in front of me here, for having found a very strong movement, the United Disabled Persons in Kenya, who have really supported us while implementing our work. After that, TCI gave us a capacity building grant, an OPD capacity building grant that lasted for 1 year, And we were able to establish peer support networks across 5 counties in Kenya: Kisumu, Nairobi, Kiambu, Nyeri, and Nakuru. So right now we are running around 5 active groups, though initially we had around 10, but due to various factors and limited resources, only 5 are actively in progress. So we've been able to take part in the national movement. We have not been left behind in the advocacy for legal and policy reforms under the umbrella UDPK. We were part of the process in preparing the shadow report that was presented before the CRPD committee in Geneva. We have also been members of the SGD forum at the national level, which our contributions have been presented this year at the high-level political forum in New York. We have also formed strategic partnerships, for instance, with Validity Foundation, and we have already filed a case on discrimination on the basis for one of our board members who was discriminated on the basis of his disability. And the case is ongoing in Nairobi. So Validity Foundation has also partnered with TCI to ensure that we have a working space within Nairobi. We have also seen the importance of including community health promoters at the community level, because they have a very strong knowledge on the CRPD naturally, though they are not aware that they are practicing the principles of the CRPD, but they have been very, very instrumental in implementing support programs for persons with psychosocial disabilities at the community level. We have also used our community sensitization meetings to sensitize on community support as opposed to the medical model. We also used sports and poetry and plays in some cases to sensitize the community on the importance of inclusion and also addressing the various intersectionalities that affect persons with psychosocial disabilities. CSE Kenya is only 2 years old. I think we have made some gains, but we're just starting our work. And so we are still mobilizing for resources because a lot has been suspended due to the limited resources, of which we feel that a lot is going to happen. And we have already contributed immensely into the community inclusion handbook that actualizes the research that was done through the Catalyst grant. And this is where we had some of our activities that supported the research that was also evaluated by Richa and Chinta. So probably for now I can stop there and wait for the questions at a later point. Thank you.
Thank you so much, Samuel. I think it was great. You highlighted some of the key factors that have supported your movement strengthening. So things like having the fellowship support, having the Catalyst grants to help take the program to the next level, and bringing that story of support systems, meeting people where they are at in their own diversity, and as opposed to the medical model that we heard before. I'm going to stop there because we're a little bit over time. Thank you so much to all of our panelists for your time and sharing your experiences with us. And I hope that you get a chance today, amongst a busy schedule, to talk to lots of people and spread the word of the resources that you have. Thank you.